Let me just start with a general question about the different forms of repeat biopsy testing, and just ask, is tissue testing the clear gold standard? In other words, is that the reference point that is the definition of the right answer, or is tissue heterogeneity the idea that there may be a relevant difference between a biopsy done in one part of a tumor or another, or in one nodule versus another, potentially enough of an issue that serum-based testing is going to turn out to be as good or better than tissue-based testing?
So I think up to now, tissue testing has been the gold standard. Specifically looking at tumors that are EGFR mutation positive or ALK positive, testing in one part of the tumor, you're likely to have similar findings, but it's when you biopsy a nodule somewhere else, that's where you may have more of the discordant results. And there's a potential that blood-based testing, because it'll give you more of a representation, may replace tissue testing with time. We're not there yet. I think that it's still early stages, and we'll always compare blood-based testing to what we consider our current gold standard before we can say this is a new gold standard.
Yeah, I think that's the challenge, right, is when we design studies, when we try to understand how things work, we have to have a gold standard and we have to compare to something. And so as many of us who are designing these blood-based biomarker tests, you know, our first thought is, let's just compare it to tumor. But Jack, you're right, you know, that with the heterogeneity of tumors, and particularly resistance mechanisms, where if you biopsy 4 different sites of a patient, you find that 2 of them have, say for EGFR, 2 of them have T790M and 2 don't. How do you know you're going to get lucky and pick the right one when you do a biopsy? And the dream is really that circulating tumor DNA or circulating tumor cells somehow give you information on all the sites. Of course, there's a lot of tumor biology and blood-based biology to make that a more complicated thing. Do we know that tumors all release into the blood at the same rate? We don't. We have a lot to learn there.
So a question comes in related to this of what kind of threshold of evidence do we need to broadly adopt serum-based testing? We are seeing more than we've ever had before, and Clovis has done a fair bit of work on that paired with ruxolitinib. What kind of threshold in terms of sensitivity and specificity are you looking for? How far are we from that? And I just throw out, I'm not sure that specificity is really going to be an issue. I mean, if you find it, it's great, you know it's there. The real issue is, how confident do you need to be that a negative test is true to have that replace something, or is it just something to do in addition to what you'd already be doing?
So I'd say for me, the gold standard and how we have to understand whether something works is about how it works for people and the drugs that we treat you with, right? So, you know, if it's concordant with tumor, who cares if it doesn't predict which drug is going to work next? And so that's how we have to figure this out, is we'd have to test people and treat them. So the data that Leora showed, that Leisha presented at ASCO this year, where she looked at the concordance and then importantly looked at the response rate of ruxolitinib in people who had tumor negative, plasma positive. And it showed that, you know, a third of patients who are plasma positive only responded. So that tells me that test works in that setting.
Other thoughts?
I agree with Greg. I think you do need a very sensitive test, because you don't want to rule out a drug that could potentially be beneficial. So whereas some of the sensitivities with ruxolitinib, it was higher than 80%. But some of these tests that have sensitivities are 40, 50%. I think that we're denying a group of patients a drug that could potentially be beneficial based on a false negative result.
So questions about, are drugs testing circulating free DNA commercially available? The answer is yes, some are, and a growing range of data. It hasn't, I would say, caught on as reached some tipping point of of being routinely used, but certainly the tests are available and kind of variably accepted, but certainly haven't become any kind of systematic replacement for tissue testing. Fair enough?
Agree.
Yeah. How about for patients who have had surgery or otherwise are without evidence of disease? They've been treated with an oral TKI. Doesn't matter whether it's ALK or EGFR. Maybe they've had surgery for the lone recurrence or stereotactic radiation. Does serum-based testing work if you can't see any tumor?
So I guess that's a good question, and it might. The deeper question is, I think, like what we talked about in the last session with CEA and markers like that, is that if we see say a T790M develop in a patient, it's a very specific thing, and it's very clear that that might be biologically relevant. But if you don't have a tumor present, it's hard to imagine it causing a symptom that would lead us to want to treat that. So it would make me scared, but it wouldn't make me want to treat. And so I think that would be that's a reason I wouldn't test.
What about, we talked more about EGFR than ALK in the realm of immunotherapy. Do you extrapolate from EGFR to ALK? I'll ask both of you, or do you think that we need to view these as separate clinical entities?
I'll just say that I think they're similar in the sense that we think of EGFR and ALK as more clean biologically tumors, so they have fewer mutations. They're not the sort of mutation they're not the sort of tumor where there are hundreds of mutations. As you saw the data earlier, they're a much smaller number of mutations than in people who have, say, KRAS mutant lung cancer. I think that makes them a bit easier to understand. I do bin them together based on the little bit of data we have. Your thoughts?
I think there's similar patient populations in terms of patients who have ALK mutation, positive lung cancer are more likely to be never smokers. But there does seem to be some emergent data suggesting differences in responses to immunotherapy, whether you're ALK positive versus EGFR positive. But it's really, really small numbers.
So not necessarily. Okay. What about activity of immune checkpoint inhibitors on intracranial disease, on brain metastases? Do we know if it crosses the blood-brain barrier and get these results, efficacy?
Yeah, maybe Leora, I'll let you address that, but there is some recent data on this.
So yeah, there was data at ASCO this year in patients with untreated brain metastases. Sarah Goldberg presented that from Yale, showing a response to PD-1 antibodies. Several of the trials have allowed patients with treated brain metastases onto the studies, and we actually have a couple of patients who've responded. The difference between the PD-1, PD-L1 immune checkpoint drugs is they're engaging T cells, and the blood-brain barrier, theoretically, T cells can cross. It's not that the T cells are restricted the way we think of antibodies and large drugs. So I have a patient who had a CR systemically and has had a CR in the brain as well, so a complete response. And the patients who seem to respond, it's not like the tyrosine kinase inhibitors where the brain is often the place of progression. If the systemic disease is responding, for the most part, the brain is responding as well.
A question about if mutational burden is important and that increases over time and lines of therapy, does it make the most sense to defer on immunotherapy until later lines when you might have accumulated more mutations? A, is there data, and B, is that an appropriate corollary?
Yeah, so there's not enough data as far as I know, and maybe Leora can add to this because she probably knows the immunotherapy world a little bit better than I do. But what I will add is that the original excitement around nivolumab came from the phase 1 trial. And as you probably know, phase 1 trials where we're trying to find the right dose may not be appealing for first-line therapy. They're definitely not appealing for first-line therapy. They're not appealing for second-line therapy. But so as a consequence, phase 1 trials often include patients who've had 3, 4, 5 lines of prior therapy and would have the highest mutational burden. And we saw very high response rates in that phase 1 trial of nivolumab. So I think it does suggest that we may be seeing higher response rates, but that's not the active area of investigation. I'll let Leora address it further.
So I agree with Greg. With the phase 1 trials, Naya Rizvi looked at mutation burden in lung cancer patients on pembrolizumab. And he compared mutation burden and PD-L1 testing. And if patients who were on pembrolizumab had high mutation burden and were PD-L1 positive, their responses to pembrolizumab were very good. If they had high mutation burden and were PD-L1 negative, their responses were as good. If they were PD-L1 positive but low mutation burden, they did not appear to respond. The problem with mutation burden, and he was doing exome sequencing, is it's very costly. It takes a long time, and so it may not be the most appropriate way to figure out who is going to benefit. There are a group of patients, and we have them, I'm sure you have them at Memorial, and I'm sure you have them as well, Jack, who are responding to immunotherapy first line. Those patients had to have been PD-L1 positive to enroll in the study. And we can't really figure out exactly who they are because some are big smokers, so higher mutation. Some are very light smokers or quit 30 years ago. The first-line trials have excluded patients who are EGFR positive or ALK positive. They haven't allowed them on the studies because we know how effective targeted therapies are. So maybe if we allow those tumors to get higher mutation burden with time, we'll get a greater benefit, but we don't know yet.
Yeah, and I would just add that I think the data that we have so far where EGFR mutant patients who have resistance and have gone on to nivolumab, the data has been disappointing.
We'll talk a bit about combinations. Certainly, most of these immunotherapies are being tested in the first line and potentially other settings in combinations with everything that is standard therapy, every chemo combination, and now increasingly also in combination with EGFR inhibitors, ALK inhibitors, et cetera. Any thoughts on how appealing that is? And then we'll turn to the idea of combinations of immunotherapeutic agents. Let me start with you, Leora.
So I think as oncologists, we like to take what we have and add. And we don't always think about how we're adding. And so I personally have not been a huge fan of the combination chemo with immunotherapy. The data is fairly preliminary and maybe there is not more side effects. But a lot of the trials, I think, will have the same tail of the curve where we see a group of people who are responding and have a durable response and survival, but maybe those are the same people who never needed immunotherapy. And a lot of the trials that are going on right now are comparing chemotherapy with immunotherapy compared to chemotherapy alone, but we never look at what if you just got the immunotherapy alone. We're also combining them with EGFR inhibitors, we're combining them with ALK inhibitors, and I think part of the problem is we have not clearly defined the best group of patients who will benefit from immunotherapy. So similar to what we did a decade ago with EGFR inhibitors, where we just added them to everything, and really nothing was better than the EGFR inhibitor alone. We may be doing a bit of that again. There's emerging data with safety, but it's really preliminary.
Yeah, the only thing I would add to that is that you can come up with an immunologic rationale as to why you would combine, say, tyrosine kinase inhibitors with immunotherapy, with the idea that if you kill a bunch of cancer cells with the chemo or with the targeted therapy, that it kind of liberates antigen, which the immune system, which is then activated, could lead to a more effective response. This is, of course, all hand-waving, and we have to actually treat people to see if this works.
Yeah, I think part of it is we really want to do this. Let's go back up and find a reason why we would do it.
Yep.
And then, truly, I mean, I think basically the approach to immunotherapy and cancer is a shotgun approach of everywhere there's a pellet, sprayed on the landscape of what you'd want to do in in standard treatment, just add immunotherapy to it. But the upside is we're going to have actual data speaking to this in the next few years, and we'll see. It does need to be compared to the concept of doing these things sequentially rather than combining them. That brings up another question, which is, of course, we just got an approval, there was an approval in the setting of melanoma for the combination of nivolumab, Opdivo with Yervoy ipilimumab, and you mentioned that. That's not lung cancer, but the question is that, how optimistic are you that that is where we are going, where we should go, and is that a more appealing concept than doing some of these sequentially?
Yeah. Leora's the expert on this one. I'm going to leave it to her.
So it's been more in small cell lung cancer that we've looked at this, and there was some data from the phase 1 trial combining nivolumab with ipilimumab, showing higher response rates compared to nivolumab alone. Small cell lung cancer is a very different disease from non-small cell, and that phase 1 trial is actually going to reopen with another 250 patients, looking at 150 getting nivolumab alone and 100 getting the combination. What I worry about with the combination, and there is a non-small cell trial that is doing that, what I worry about with the combination is the melanoma patients are a different patient group, and I do think that they're a slightly healthier patient group, and they're younger. The average age of lung cancer is age 72, and nivolumab and ipilimumab is a fairly toxic combination. And there are far more toxicities with combination nivolumab and ipilimumab, more pneumonitis, more colitis. We have more patients being admitted. And so I just think that we need to be very careful which lung cancer patients we're giving these combinations to. There's also a combination trial with durvalumab and tremelimumab. Durvalumab is the MedImmune PD-L1 inhibitor. And so they're looking at that combination as, I think it's third line right now.
And tremelimumab is another CTLA-4, similar to Yervoy.
Correct. And they're looking at that combination in non-small cell and lung cancer patients. But I don't think we can underestimate the toxicities that combination therapy gives, far more than single agent.
Okay. We're going to wind up, we're going to go on to lunch in a minute. I just want to ask a couple more questions that have come in, and there's still a few that I know we'll have to defer. One is, are there liquid biopsy tests for looking for mediators of ALK acquired resistance? I would say no, as far as I know.
Yes, there is. There's one company that's doing that, and we've actually looked at the liquid biopsies from patients on the X396 trial.
Okay.
But it's through next generation sequencing.
Okay, and still not widely used
No.
at all?
No.
One on Veristrat for switching EGFR TKIs. I think it's important just to say Veristrat's really not a clinically useful test outside of the question that has been presented for EGFR wild type, not for clinical decision-making for patients with EGFR mutations.
Yeah, I would emphasize
Correct.
that. For people with EGFR mutations, Veristrat is not a useful test. I've never in my career ordered a Veristrat
Yeah,
test.
I think the other point is it's of dubious value for anybody, but
Yeah.
it's definitely not really something that we should want to distract ourselves with. And then really a question about are there clinical characteristics associated with a better chance of immunotherapy success, particularly if somebody progressed rapidly on EGFR inhibitor or ALK inhibitor therapy? I don't think we know that.
We don't have the only clinical characteristics really are those things that I showed you in that forest plot with heavy cigarette smokers maybe having a somewhat higher likelihood of response.
Okay, so thank you very much. We are going to break for lunch.